Fetal placenta derived from which layer? Zona basalis, zona basalis, zona capsularis, zona parietalis, inner cell mass. And the answer is basalis. So fetal placenta derived from zona basalis. So placenta, fetal placenta is weight is 500 gram, and weight of placenta is to weight of ratio of weight of placenta and of fetus is 1:6. This is the normal ratio. Okay, human placenta is discoidal, very important. This point is very important. Discoidal, that means disc-shaped, and deciduate, that means shed off during delivery. It's get shed off during delivery. So first of all, discoidal, that means disc-shaped. Disc-shaped. Next is deciduate. Deciduate. Okay, it shades off during the delivery. Number 3 is hemochoroidal. That means in contact with maternal blood. Hemochoroidal. It is formed at decidua basalis, formed by trophoblast. Very important. Formed by trophoblast at decidua basalis. Placental circulation established at 21 to 22 day. Same time the heart is formed, hence the fetal circulation is established. Okay, so always remember these 3 characteristics of human placenta, that is discoidal, disc-shaped, deciduate, shed offs during the delivery, and hemochoroidal, it is in contact with maternal blood. Okay. So this is about fetal placenta. Next is placental circulation established by 21 days. Fetal circulation is established by 21 days. Weight of placenta at term 500 gram. Functional unit of placenta lobule. Surface area of placenta at term 12 square meter. Placenta takes over function of corpus luteum at 8 weeks. Placenta takes over the function of corpus luteum at 8 weeks, 8 to 10 weeks. Okay, so these are some of the points, important points of placenta. Okay, next question. According to the rule of 5, to when is the fetal head engagement? Okay, so the answer is 1/5. 1/5 of the fetal head palpable. So since the type of pelvis may vary from one woman to another, it may be gynecoid, android, anthropoid, and platypeloid. Platypeloid, the spelling is wrong here, not lipoid, platypeloid. So only effective measure of fetal head descent that reflects engagement is suprapubic assessment. So for measuring fetal, do remember fetal head descent. Fetal head descent, we go for suprapubic assessment of how much of the fetal skull remains palpable. Suprapubic assessment. Assessment should be done at suprapubic region. The amount of fetal head felt suprapubically. So suprapubic assessment should be done at suprapubically by feeling the fetal head, by palpating. We need to palpate the fetal head at suprapubic region. In finger, breath is assessed by placing the radial margin of the index finger above the symphysis pubis. So where to keep the finger? We need to keep the finger at the above the symphysis pubis, Which finger? Index finger. Successively until the groove of the neck is reached. Okay, this is how suprapubic assessment should be done. Suprapubic assessment should be done when the fetal head is 1/5 of the above. The sincipute can be felt abdominally, and 1/5 represents a head entirely in the pelvis with no pulse felt abdominally. No pulse felt abdominally. So you see the pelvic brim is completely above the pelvic brim. Then pelvic cavity. This is the pelvic cavity hole. Sincipute, high occiput felt, easily felt occiput. Then sincipute easily felt while occiput felt. Sincipute felt, occiput just felt, and sincipute felt, occiput not felt, and none of the head palpable. Okay. Okay. Next question: duration of the second stage of labor in primipara. So the answer is 2 hours. Very important. The stages of labor. What are the stages of labor? Stage 1, stage 2, stage 3, and stage 4. Very important for FMGE. Very important for FMGE. This stage 1 is from uterine contraction to full cervical dilation. Uterine contraction to full cervical dilation. Contraction to dilatation. Remember. Contraction of what? Uterus. Dilatation of what? Cervix. Okay. In primipara, the woman having children for the first time, and multiple para means more than first time. Second, it may be second time, third time, fourth time, and all the after first time it's multipara. So for stage 1, this is stage 1. Next, stage 2. Full dilatation to delivery of the baby. Full dilatation to delivery of the baby. To stage 3. Next, stage 3, delivery of the baby to placental delivery. Delivery of the baby to placental delivery. And number 4, after postpartum, means after whole birth, 1 hour of 1 hour postpartum period to rule out postpartum hemorrhage and vulvar hematoma. Okay, so you need to wait for 1 hour, to keep the mother wait for 1 hour, so that to ensure that there is no PPH or vulvar hematoma. That's it. It's 1 hour for both primi and multipara. Otherwise, stage 1 for primipara, stage 1 is 12 hours, then stage 2 is 2 hours, then stage 3 is 15 minutes only, because delivery of the baby, only delivery of the placenta is left. That is 15 minutes. Both for 15 minutes, from primi or multipara, both for both it is 15 minutes. Okay. And for the main thing is the dilatation of the cervix to delivery of the baby. It takes time, actually. It takes the biggest time. For primipara, it may takes up to 2 hours, while for multipara, it's just 30 minutes. Just 30 minutes. And in primipara, from uterine contraction to full cervical dilatation is 12 hours, while in multipara, it's 6 hours. So, so the thing is, in the stage 2 is a very important stage. Full dilatation of cervix to baby delivery of the baby. Okay. So do remember the duration and the stages of labor, and the definition of the stages means what happens, the events of each of the stage. Very important for FMG, very important. So duration of second stage of labor in primipara, second stage of labor 2 hours, right? Okay, next question. Amniotic fluid at term is 1000 ml to 1200, 800 to 1000, 900 to 1000, and 700 to 800. So the answer is 800 to 1000. So normal amniotic fluid volume. Amniotic fluid volume increases as the age of gestation increases. So at 10th week it is 30 ml, at 16th week it is 200 ml, third trimester, in the third trimester it is 800 ml. Amniotic fluid is maximum at 28th week age of gestation, that is 1000 ml. Maximum at 28th week of 28th week, that is 1000 ml. Okay, the fluid approximately is 98% water. A full term fetus contains roughly 2800 ml of water, and the placenta another 400 ml. So the term uterus holds nearly 4 liters. Term uterus means uterus at term, at almost at at almost 40th week. So uterus at 40th week, 40th weeks contain what? Number 1, 1000 ml of amniotic fluid. Next, 2800 ml of water. Water in fetus. Then placenta is another 400. 400 is placenta. Placenta another 400 ml. Water from placenta. Okay, water from placental water. So uterus holds nearly how much? Nearly holds 4 liters of water. So this much ml. Okay, so 4 liter of water. Uterus at 40th week, term uterus. So fetal uterine production begins between 8 and 11 weeks. Very important. 8 and 11 weeks fetal urine production begins. It does not become a major component of amniotic fluid until the second trimester. Now the later observation, that this amniotic the fetal urine becomes major component of amniotic fluid in the second trimester. This observation explains why fetuses with lethal renal abnormalities may not manifest severe oligohydramnios until 18 weeks. Until 18 weeks. Means almost until second trimester. So what it means? If a fetus is having renal abnormalities, there should be oligohydramnios, because most of the amniotic fluid is contributed by the fetal urine production, but from second trimester. So up to second trimester, if a fetus has any renal abnormalities, there is no oligohydramnios, because fetal urine start contributing as a major component of amniotic fluid from second trimester. So till second trimester, even if the fetus has renal abnormalities, we cannot understand. Okay, that is what they're telling. So fetal urination is the primary amniotic fluid source by the second half of the pregnancy. Now by the term, fetal urine production exceeds 1 liter per day, such that entire amniotic fluid volume is recirculated on a daily basis. Fetal urine osmolality is significantly hypotonic to that of maternal and fetal plasma and similar to that of amniotic fluid. In order to attempt any question related to topic, we have summarized. So anyway, we have summarized the amount of amniotic fluid and fetal weight according to gestational age. So here we can get some summarized fluid volume with gestation, period of gestation with fetus weight and amniotic fluid corresponding values. Okay, you can go through it. Okay, next question. Bishop's score includes all of the following except cervical consistency, dilatation of cervix, position of cervix, and cervical length. And the answer is Bishop's score includes all. Bishop's score includes cervical consistency, dilatation of cervix, position of cervix, but not cervical length. Bishop's score is used to predict what? Success rate of the induction of labor. Success rate for the induction of labor. Success rate for labor induction. Remember, this is Bishop's score. Bishop's score includes dilatation of cervix, position of cervix, presenting part of the fetus. And consistency of the cervix. It doesn't include length of the cervix. Remember, very important. Doesn't include length of the cervix. So Bishop's score basically predicts, help us to predict the success, how much labor, predicts whether the labor has started or not. Whether the labor started or should start shortly or not. Okay. What is the status of labor induction? Bishop's score is very it's used for this purpose. Okay. So you must remember the factors or the parameters that are included in Bishop's score. That is dilatation of the cervix, position of the cervix, presenting part of the fetus, and consistency of the cervix. Okay, so next question. Year of primigravida, 35-year-old primigravida visited your clinic. Okay, USG is shown here. It's revealed here. What is the diagnosis? Anencephaly, holoprosencephaly, nuchal translucency, and hydrocephaly. And it is nuchal translucency. Nuchal translucency is the fluid behind the neck of the fetus. You have to see here. This is the fluid behind the neck of the fetus in anechoic space visible and seen in all fetuses between 11 to 14th week of age. The most common cause of increased nuchal translucency more than 3 mm is aneuploidy. But Turner syndrome, where Turner syndrome is the most common cause, followed second by Down syndrome. So most common cause of increased nuchal translucency is aneuploidy, number first. Where Turner syndrome is the second one, and third is followed by Down syndrome. Reason why it is seen in 11 to 14th week is because at this time what happens, fetal lymphatics are developing and peripheral resistance is high and gradually disappears. So this is why there will be anechoic space visible. Okay, and nuchal translucency occurs. It's the fluid behind the neck of the fetus. This is the fluid shadow. Okay, so we will continue with obstetrics and gynecology in the next class. As you know, as per the schedule, there will be 2 classes of obstetrics and gynecology. So the other questions we will do in the next class. Okay. Okay. Thank you very much. And the next class will be on Tuesday. Okay. Thank you for today.